My name is Daniel Diaz. I'm a PGY3 in internal medicine at HCA Florida Kendall Hospital, and I, along with my colleagues and our attending cardiologist, Dr. Hector Crespo, would like to present our case of a myocardial bridge, a bridge too far, myocardial bridge requiring unroofing complicated by post-cardiac injury syndrome. As a brief form of background, the prevalence of myocardial bridging in literature varies significantly depending on the diagnostic method. Coronary angiography reveals a prevalence of 6%, while autopsy reveals a prevalence of 42%. Our case presents a 49-year-old female with past medical history of hypertension and hypothyroidism, presented to the emergency department complaining of constant excruciating pressure-like substernal chest pain with left shoulder radiation that began 3 days prior to arrival. Upon admission, her blood pressure was 163/96, with vital signs otherwise being unremarkable. Workup was significant for a high sensitivity cardiac troponin of 1.7. EKG and TTE were otherwise unremarkable, and patient was started on treatment for N-STEMI with aspirin, sublingual nitro, metoprolol, and heparin drip. Patient's troponin continued to increase during the following 24 hours and peaked at 22.2. Based on these findings, the patient was taken for left heart cath and was found to have a 50 to 60% segmental eccentric stenosis in the middle LAD segment, which was aggravated by moderate myocardial mid-LAD bridge, which is seen here in figure 1 with cardiac CT showing invagination of the LAD into the myocardium. And in figure 2, we have images from the coronary angiography showing here the mid-LAD myocardial bridge. Patient was started there after that on calcium channel blockers as a treatment for the myocardial bridge. However, her chest pain remained and continued to worsen. CT surgery was brought on board, and they decided to take the patient for an unroofing procedure in which the LAD was immobilized and the surgeon was able to free approximately 1.5 centimeters of overlying muscle in the LAD, after which the patient's symptoms improved and she was discharged shortly after. Patient would return 1 month later, however, with pleuritic chest pain, was diagnosed with having post-cardiac injury syndrome, formerly known as Dressler syndrome, and treated with aspirin and colchicine. Myocardial bridge, the compression of the coronary arteries, occurs during systole, while most of the blood flow and oxygen supply to the myocardium happens during diastole. This pathophysiology leads to asymptomatic presentation seen in most patients. However, in patients like ours, the coronary compression of the coronary arteries has been shown to persist during diastole, which causes decreased myocardial perfusion. When this occurs, these patients may present with a wide variety of clinical manifestations, ranging from asymptomatic to ACS to as far as sudden death. This array of presentation has no correlation to the length or depth of the tunnel segment, nor the degree of systolic compression. The preferred method of diagnosis for myocardial bridging is coronary angiography. As the myocardium contracts during systole, the lumen of the artery is narrowed and returns to normal diameter during diastole. Intracoronary ultrasound is another diagnostic technique and provides additional information, including the length, depth, and position of the tunnel arterial segment. The pharmacologic treatment of symptomatic myocardial bridging includes beta blockers and non-dihydropyridine calcium channel blockers. Through their negative chronotropic effects, these agents can increase the diastolic coronary filling period and thereby decrease the compression of the involved arteries. Antiplatelets may also be used if atherosclerosis is detected. If these treatments are unsuccessful, a patient may be considered for surgical procedures which may provide therapeutic relief, including unroofing with myotomy of the myocardium, CABG, as well as stenting of the coronary arteries. The unroofing procedure can be performed safely with almost no cardiac-related deaths and 63% of resolution of chest pain. Compared to stenting, unroofing procedure eliminates the risk of restenosis, stent thrombosis, and perforation during stent deployment, and compared to CABG, eliminates the risk of graft failure. Moreover, this procedure has been shown to reverse local myocardial ischemia and increase coronary blood flow. Due to the risk of myocardial ischemia associated with myocardial bridging, patients may develop post-cardiac injury syndrome, commonly known as Dressler syndrome, due to the inflammation of the pericardium during the initial 8 weeks following the ischemic incident. The narrowing of the coronary blood vessels due to the muscular compression produces the same immune-mediated responses to ischemia as seen in atherosclerotic myocardial infarction. It is therefore important to be aware of this complication with symptomatic myocardial bridging, and patients may be treated with NSAIDs for 4 to 6 weeks in mild cases and if refractory with corticosteroids.